So of course, ARDS as a concept and ARDS ventilation as a strategy have been evolving right since the advent of ARDS as a recognized clinical entity in 1972. So the story of evolution of mechanical ventilation itself, all these concepts. So what do we know so far in a nutshell? ARDS is an inflammatory response. It's not a disease, it's a syndrome. It's actually an inflammatory response to many stimuli, both primarily pulmonary and extrapulmonary. So alveoli and the interstitium are flooded with proteins and cytokine-rich fluid. So there is a hypoxemia. Originally it was termed as refractory hypoxemia until they bumped into PEEP. So on the application of PEEP it is correctable. A lung injury may be perpetuated iatrogenically as well. It's not just the primary injury by the disease. Once we ventilate the lung, then there is a second hit by the ventilation strategies themselves. This is called so-called ventilator-induced lung injury. And so we discovered in the mid-80s through animal experiments that these are real, ventilator-induced lung injury. And so we modified our ventilatory strategies to a lung protective one. So we cannot directly ascribe the degree of harm, but we know there's an attributable mortality to VILI. And if we take into consideration all the experimental and clinical evidence, in an unquantifiable way, VG has played a part in the mortality due to ARDS. So the Berlin definition in 2012 made it a straightforward classification. It should be 1 week, within 1 week of known insult. Okay. Be it primarily a lung infection or trauma, or extrapulmonary infection and sepsis, or distant trauma, and or drugs, toxins, and so on. So radiologically you see bilateral infiltrates, but you may not see it just on plain X-ray sometimes, if it's very early. So it's the CT scan which reveals it. And then what is the origin of edema? We used to believe that it has to be non-cardiogenic. Originally we believed that it has to be a pulmonary artery opening pressure of less than 18 millimeter of mercury. But then we know now that in a pre-existing heart failure also, you may develop ARDS due to various causes. So a hypoxemia not explained fully by a baseline heart failure, so that is got integrated into the definition. So severity has been classified according to the PF ratio, as you can see, mild, moderate, severe. Luciano Gattinoni, who is a big name in ARDS and continues to be after so many years, from Italy. So he showed us that contrary to what we believe based on plain X-ray, that's an inhomogeneous disease. So ARDS has a very heterogeneous distribution. You can see this is a typical ARDS appearance, where there is a dependent consolidation, right? And early on it's associated with bilateral pleural effusion, and later you get fibrotic changes and subpleural cysts, and pleural effusions disappear. So ventilator-induced lung injury can be based on oxygen toxicity. We all know above 60% FiO2 or 0.6 FiO2. There is susceptibility for oxygen toxicity, and the lower the oxygen dose, the safer it is. Barotrauma is the macroscopic evidence of injury, but it is the structural injury which constitutes VILI. Volutrauma, the excessive alveolar stretch. Atelic trauma, due to alveolar underfilling and collapse, so a forced opening in every inspiratory cycle induces injury. Biotrauma, only 50% of patients die primarily of respiratory failure. Majority die of multi-organ failure. So there's a huge amount of cytokine response which spills over into the bloodstream and then leads to multi-organ failure. Now we have come to recognize since 2015 the concept of ergotrauma, that is the energy, the mechanical power that is delivered to the lung during mechanical ventilation also is potentially injurious and may be the composite concept of how everything adds up to lung injury. So in the 80s you had the experimental evidence where Dreyfus showed that high inspiratory pressure and volume in animal lungs produce overstretching and then huge edema and increase in lung weight. Lung weight may increase 3 or 4 times. We produce diffuse alveolar damage microscopically and patchy areas of inflammation, hemorrhage, in hyaline membrane formation, very much like ARDS. So it becomes indistinguishable when there are second hits due to really what is doing what. So that's why you can't distinguish it on the basis of X-ray or CT scan. They would all look alike. So volutrauma is not only the static alveolar pressure, the steady pressure, it is also the rate of stretch and the degree of stretch, the amplitude of stretch. And hyperinflation may affect the vascular structures as well, increasing the permeability and adding to the lung injury response. So ventilation, low lung volumes produce this kind of heterogeneity, and those alveoli which are near collapsed to collapsed, if forced open, they result in lung injury. This is primarily due to lung inhomogeneity, and this is very individual. See, the degree of homogeneity varies from person to person. So the personalized ventilator settings are called for. You can't make one glove that fits all. You can see that when an open lung and closed lungs are juxtaposed, then huge pressures are created at the interface. So this is also something to be understood, and all these play a part in the creation of VILI. So we have 2 models of the ARDS lung. One is called the baby lung, where this you can see at the bottom there's a lot of water, solid, collapsed. In the middle there is some open lung, aerated lung. The top is the aerated lung. So functionally there is only the top and some part of the middle that is operational and is taking part in the gas exchange, taking part in the tidal breath. So this is the baby lung. It is not even if you get an idea of the lung size through predicted body weight, The functional lung size much smaller, it's called baby lung. It's also sponge lung because the water gravitates down, right? Like a sponge. And so, if you're supine, it settles at the back, and if you're prone, it settles ventrally. This is very important. What happens with this pressure time graph? This is all familiar to everybody. So you can see the peak airway pressure in this volume targeted lung ventilation. So this is dynamic. Okay. This is a dynamic pressure, which is part of it is dissipated in the proximal portions of the airways. Then you apply plateau pressure, and this is the static pressure, distending pressure of the alveolus. Understand? So here the energy is expended as a plateau pressure, and then the pressure settles down either to zero or to the PEEP level. So PEEP is the level above baseline, which also adds to volume because it raises the FRC, functional residual capacity. So it's not that PEEP is not contributing to stretch. Okay? PEEP 2 is contributing to stretch. So you can see the higher the PEEP, more will be the plateau pressure. It's reflected in the plateau pressure unless the PEEP opens up, potentially recruitable lung, and then in effect the global pressures come down. Okay, so again the PEEP setting has to be within the plateau pressure limits. If it is above the plateau pressure limit, it's going to contribute to relief. So in the ARDS network investigators, in the year 2000, which is so often quoted and most of our practice is based on this paper, they had these sort of hypotheses and consensus guidelines. Much of it is not evidence-based. The only evidence we have is of the tidal volume. We keep the tidal volume low, 6 to 8 ml per kg as opposed to 10 to 12 ml per kg. You have big difference in mortality as well as in the time on days on ventilator. Through experimental evidence and through consensus, and perhaps now through epidemiological evidence, we have fixed this plateau pressure limit as 30 centimeter water. It's not to say that there is a switch just below 30. At 29 you're safe and at 31 you're unsafe. It's not like that. A ballpark number. Better to keep it much less. Say 27, 28, target that rather than exactly 30 if you can help it. I know it's a trade-off when you're setting the ventilator. You've got to look at the oxygen, you've got to look at the hemodynamics, you've got to look at the PF ratio, you've got to look at the plateau pressure. So all these have to be combined. And respiratory rate, they thought wasn't contributing much to the relief. So they said you can go up to 35 breaths a minute. If that's required to keep the carbon dioxide at acceptable levels. You don't have to get a squeaky clean ABG. That is not the target. Right? If you want to target absolutely normal PaO2 and CO2, you are not going to provide safe lung protective ventilation. But that's the most important. ARDS ventilation, it's not just to keep the oxygen going or to keep carbon dioxide reasonably down, it is to provide ventilation at safe levels with respect to the possibility of VD. So ARDS network, having only one evidence-based data, which is tidal volume, and other arbitrary guidelines with respect to respiratory rate and PEEP. They had a PEEP FiO2 ratio table. Right? You just follow the table without asking questions. Right? So this was the basis of our ventilatory practice for at least a decade or more after this ARDS network trial. We wanted to find evidence for PEEP. Even at the outset, there was no evidence of PEEP. Ashbog and Petty, we arbitrarily dialed up the PEEP and found that oxygen is correct. Many things are like that in medicine. The practice precedes evidence generation. So in the alveoli study, where they pitched the PEEP at higher levels at each FiO2 point, it did not produce any material difference in the outcomes, either in terms of mortality or in terms of ventilator-free days. However, we got to understand that there is a subset of very severe disease where the higher PEEP may work better in reducing the need for rescue therapies. Right? So other studies came about, LOE and EXPRESS trials, which reveal that there is a subset where higher PEEP may be employed usefully. PEEP setting is a vexed issue. We are all aware that we have to individualize it, personalize it, but we really don't know how. We've tried various ways. In the last 50 years, in the end, we only know that we have to pitch it somewhere between 10 and 15 centimeter water. We should keep the tidal volume low in order to collectively keep the P plateau less than 30, except higher PCO2. Okay, so that is permissible hypercarbia as a concept, but nobody has said which is a level of PCO2 which is acceptable and which is a level of pH which is acceptable, maybe 7.2, provided there is no cardiac comorbidity, and perhaps a PEEP of 15 or more, provided there is no ICP, right? Another injury, brain injury. So we have to keep an eye as well on hemodynamics and other things. So brain injury is another issue wherein if you have ARDS as well, it becomes a complex interplay where you have to monitor very closely the ICP and the cerebral perfusion pressure in order to get your PEEP right. So what are the methods? Now Amato in the late 90s, early on it was on shunt fraction, it was on oxygenation initially, then on shunt fraction. Then Amato said the lower inflection point, we should pitch the PEEP above the lower inflection point and below the upper inflection point. So he plotted it on the basis of static pressures, using a super syringe at every point. However, there is recruitability of the lung all through this limb. It is not that it just recruited only here, all through, and it didn't show too much difference in the outcome, how you set the PEEP. Probably the mortality benefit Amato showed in his paper in 1998 was because at the intervention side it was 6 ml per kg and at the control side it was 12 ml per kg. So based on plateau pressure, which is what we are generally doing, based on compliance, many people do it to the optimal or maximum compliance. And then this stress index also came about after the turn of the millennium. That is this pressure time graph with a constant flow ventilation If the stress index is less than 1, then it's concave up, you're overstretching. If it is straight, you're optimal. If it's concave, then you are underventilating, right? Now, Gattinoni is one of the very few who is able to do CT scan on his patients in the ICU, and he's able to adjust PEEP through direct visualization of the amount of, he quantifies the amount of aerated lung before and after application of PEEP, and based on this, some lungs are recruitable, some are not. So you can't be applying the same PEEP to everyone. Those who are not recruitable, you may only be producing harm, injury, not only to the lung, but also to the hemodynamics. And now we also know that greater the energy output, greater are the chances of VLE. We'll come to that. So this is a non-recruiter as opposed to the previous one, recruiter. We also know, you see, this is supine position, prone position. The stretchability, recruitability may vary in the supine and prone positions. This is a PET scan in an experimental animal. So you can see there's a high uptake in the middle, right, where there is lungs are open, not at the bottom where the lungs are closed. So you may not open the lung, but you may injure the already open lungs. That's not a great advantage, is it? So these are the problems on the ground. And now there can be regional, within region variations. As we showed, there could be collapsed lung juxtaposed with an open lung. So there are regional inhomogeneity or heterogeneity which may aggravate this lung injury. What of recruitment maneuvers? Recruitment maneuvers are based on the fact that a high opening pressure is required to pop open the collapsed lungs. Like a balloon. Collapsed balloon, you have to push in air at higher pressure than later. So to pop it open and to then open it further, there is a difference in the pressure you apply. And when it is overstretched, then you need to apply more pressure. So there is that straight portion of the sigmoid curve where it is most stretchable and most easily distended. So if you apply recruitment maneuver to pop open the lung, then the lung may remain open with less effort. Right? This is the concept. So there are various ways in which you can keep the lung, open the lung and keep the lung open. That was a concept which was going on, about 20 years back, and then gathered speed. So we could do recruitment maneuvers in various ways. 40 centimeter water of CPAP for 40 seconds, and then crescendo, decrescendo using pressure controlled ventilation and PEEP, keeping the driving pressure safe, and so on. However, in 2017, this theory was debunked by this ART paper. This was a trial which demonstrated that if you keep the lung, you open the lung and keep it open through regular systematic recruitment maneuvers using the crescendo decrescendo method, you do not improve mortality, you do not improve other clinically useful outcomes, and there is actually a tendency in the lower PEEP category where this was not used, tendency for them to have more survival, better survival. So recruitment maneuver as a regular procedure, systematic procedure to keep lung open has been abandoned. It's not to say you never use recruitment maneuver, only in certain specific situations, maybe at the outset when you ventilate, or after suctioning or something, or after transport or something, or when there is an acute crisis, you are not able to maintain oxygenation. So recruitment maneuvers have limited application now. So you can see that in all these ways we have tried to apply PEEP, try to manipulate oxygenation and targeted PV curve, and we looked at the gas volume and looked at the recruitability and visual estimation of what PEEP should be. So we can use CT scan, or you can use lung ultrasound, bedside lung ultrasound, which is being increasingly used now, or electrical impedance tomography. Have you seen any of that? EIT is a strip around the chest, and it measures the electrical impedance of the lung tissue and converts it into an image, but it has its limitations. It is still experimental. We do not have clear evidence of its efficacy in terms of outcomes. So in prone ventilation, as you can see, lung is not like this, lung is like this, bit conical. So when you prone, more lung is available for easy recruitment through posture, rather than a forced maneuver. So this improves gas exchange. Of course, the weight of the heart also eases. There are many other mechanisms, 4 or 5 mechanisms, in which prone position improves ventilation, oxygenation, and also potential for ventilator-induced lung injury. So it's no wonder that the ProSIVA studies show a huge mortality benefit. The hazard ratio is 0.55 for mortality in the prone position arm. So you can see prone ventilation is no longer a rescue therapy. It is a mainstream ventilatory strategy for moderate to severe ARDS. Another concept that has come about is we are not, by looking at the plateau pressure as an alveolar distending pressure, we are not directly measuring the distensibility of the lung, because there is the chest wall component as well. So if you do a pleural pressure and you are able to measure the transpulmonary pressure, and we are able to target an end inspiratory transpulmonary pressure or end inspiratory transpulmonary pressure to keep within safe range, and end expiratory transpulmonary pressure, which is a little positive, 2 or 3 centimeters, so that you don't overstretch the lungs at the end at expiration. So now this diagram shows you how to calculate it. This has been used in clinical trials. David Talmore published in the NEGM about 10 years ago, and it could be of benefit in certain situations. Let's examine that. So in the normal lung is filled through a passive process. You produce a negative interthoracic pressure, and that's how the air floods in, and you don't have any alveolar pressure at all. However, there's a small alveolar pressure, for example, in routine surgery anesthesia. Then you have a small alveolar pressure, which is non-injurious. But if you have a thick chest wall, then you have a positive pleural pressure. Right? Positive pleural pressure. So even if you apply 30 centimeter alveolar pressure, the true pressure across the lung is only 25 in the same. So if you have a thick chest or an obese individual, or where there's a lot of chest wall edema, as it happens in sepsis and trauma and post-operatively, then you may actually be underventilating the lung based on just the P plateau. So this has happened many times. People have been saved from moving over to ECMO, and they measured the pleural pressure and found that we had pitched the PEEP too low. And just by adjusting the PEEP from say 12 centimeter to 15 or 17, you could save at least a third of patients from going on to ECMO. Another concept that's come about is the driving pressure. So we talked about the anatomical lung and the functional lung, right? So anatomical lung, if you just take the weight, crude weight, you don't get a good idea. So predicted body weight, well, a little better idea, but not quite, because we do not know what is the functional lung. That varies. Functional lung is small. They are baby lungs. And how big is the baby? We do not know. Right? So driving pressure by predicating the compliance of the respiratory system to the tidal volume gets you the functional lung, or it may be computed by P plateau minus the total PEEP, extrinsic PEEP and auto PEEP. So you know what is the actual pressure across the lung. And this also has safe limits. If it is 15 or less, it's safe. If it is more, even your P plateau may be alright, however, the driving pressure is high, then that is actually correlating with the bad outcomes. In a post hoc analytical study of pooled data of all the ArtsNet trials by Amato in 2015, this came to light that a driving pressure of lower than 18 centimeter, now we know it should be even lower than that, no? 17 or less, ideally 15, we do that in practice. So this is what they found, that it is the driving pressure which is actually correlating with the mortality, because if you allow the driving pressure to go up while keeping the PEEP constant, mortality increases linearly. If you keep the driving pressure constant, allowing the PEEP to change, then we don't get any difference in mortality. And the reverse. If the driving pressure is allowed to reduce, go down, even if we increase the PEEP, we have mortality advantage. So this is by pooled data, not by a prospective trial. So that is a limitation of these findings. I must also mention to you, patient self-induced lung injury, which came to light at the COVID times when most people were on an IV or on a high flow nasal oxygen, and we were wary of putting them on a ventilator. But you can there could be self-induced lung injury because the transpulmonary gradient of pressure could increase if there is dysynchrony, right? So if the NIV is delivering a breath and you are breathing against it, then there could be negative intrathoracic pressure superimposed on the delivered pressure, and you get a huge transpulmonary pressure. Right? So potentially this can injure. We have an indirect evidence in the lung safe study, which is again an epidemiological observational study. In about 50 countries in the world, they did observations over 4 months, and the mortality correlated adversely when there was a previous NIV failure. At the end of 1 or 2 days, previous NIV failure, there was a higher mortality with matched cohorts. So this is one evidence we have, so we should be wary of this as well. Now I mentioned ergo trauma at the outset. there could be a unifying concept now. How all these values, we only took tidal volume, we've only taken P plateau. We do not know very much about P, what his contribution to VD is. We do not know what are the other settings doing. Respiratory rate, mean airway pressure, minute ventilation, flow rate, flow pattern. We are not taking any of these into consideration. However, injury happens because of force. You agree? Force exceeds a certain threshold, injury happens. If within the threshold you are applying force, and most of this force is either dissipated or utilized in the objective of expanding the lung, there is no remaining force energy to injure the lung, right? And nothing happens. But if there is excessive force, which is called stress. Stress is the force that you apply. Strain is the change in the shape or size from the baseline unit. Rate of change or change. The stress and strain both contribute towards VD. So are we taking all of the potential factors into consideration in computing stress? That is the question. So again, Gattinoni, who has been a pioneer all through, proposed this concept of the machine power that is utilized to ventilate the lung and use this calculation wherein you can see mechanical power depends on the minute ventilation, the tidal volume as well as the respiratory rate, the peak pressure, PEEP, as well as the flow rate. Okay, and in different ways, not that they have equal contribution. Tidal volume may have a big contribution, PEEP may have a smaller contribution, and respiratory rate may have a little smaller than tidal volume, but more than PEEP. So this sort of calculations are now available, but they are of course based on sound physiological principles and mathematics, okay, rather than on clinical evidence. So how it is calculated, you can see this is the resistive forces, okay, this is the mechanical energy required to overcome resistive forces, and this triangle is the viscoelastic forces, elastic forces, and then this rectangle is the energy required to apply PEEP, right? So all of this is calculated and converted into a mathematical formula. We have some experimental evidence. In 30 kg pigs, mechanical power has been calculated and correlated with injury. So 12 joules per minute, right? That is the number we got generated. So that seems to be the threshold in animals. Right? Above this may be injurious, and less than 3-4 joules is also injurious. So somewhere in between 4 to 12 joules. Epidemiological evidence from human trials, they went back and they post hoc analysis of all the energies that were used, calculated, and the number appears to be 17 joules, right, for human beings. But again, these remain theoretical until we are able to show benefit applying this by the bedside. So you can see if we integrate this concept, so we analyze a concept. So there is a little paradigm shift in our concept. We are no longer confined only to looking at tidal volume, P plateau and PEEP. Our awareness is improved further, expanded to include respiratory rate and also the flow rate. The higher the flow rate, the more is the potential for injury, more is the energy expended. So you can see that power can correlate with wheelie, and it is the damaging energy per tidal cycle, but also the frequency of high stress cycles and duration. Frequency and duration. Longer and longer. When you're pulling at a rope hard, then the different fibers of the rope, peripherally they fray, right? They fray. And they give way. They keep giving way. If you're still going on, the point comes when the whole rope gives way. So this is the concept. So if an injurious cycle goes on at a certain region of the lung and keeps going at a high frequency and for a prolonged period of time, repetitively, then it can induce serious consequences of wheelie. So this is the concept. So that is why also it may be useful to vary the tidal volume. There are now ventilators available which can automatically vary the tidal volume. You don't have to have a fixed one. So that the strained units are not repeatedly strained, okay, at the same point. So this may be of value. Some people believe that this variability in the tidal volume reduces wheelie. And allowing spontaneous breathing in between also reduces the chance of wheelie. So this correlates with this sort of concept. So you can see to look at flow amplitude and profile, keep the flow amplitude low and the flow rate, that is flow rate, as low as possible. And plateau pressure we have discussed, peak we have discussed. Expiratory flow. Now, to expand in the lung, you've got a potential energy to collapse. If this collapse is very rapid, again it just makes the lung vulnerable to injury. So the expiratory flow rate may also have a value. There's a query attached to it. So where are we now? Amplifiers of stress are reduced size of the baby lung, mechanical heterogeneity, viscoelastance, and dropout of stress-bearing elements. I mentioned to you the concept of dropout in that rope. Threshold for mechanical injury also depends on the vascular pressure and flow. So neither overfilling nor underfilling the vasculature. Baseline lung inflammatory state. So you have to treat the cause thereof. Lung inflammation, and so this is the concept that has been described by Marini, Rocco, and Gattinoni, three very big names in ARDS ventilation. So if you look at the guidelines of 2019, strongly favoring is tidal volume and prone positioning. High frequency oscillatory ventilation is out of favor, gone. Conservative fluid management, well, maybe, may not be, right? But don't overload. Higher PEEP, don't know much, maybe worth trying as a rescue measure in difficult cases. Neuromuscular blocking agent may be useful because they may reduce the patient's self-induced lung injury. Because if at the outset, when you're very sick, the respirator is high, there may be greater chance of dysynchrony, and if there is dysynchrony with the ventilator, greater chances of self-induced lung injury. ECMO, we don't have robust evidence, but we have evidence of its utility as a rescue method. Inhaled vasodilators, don't know. Corticosteroids, whether it can be extrapolated beyond COVID induced ARDS, maybe, may not be. Right, that's also, we can't say with assertively. And extracorporeal carbon dioxide removal may also help in minimizing wheelie by interfering early enough and when your P plateau is high, at the same time It's not so bad that you need the full ECMO, partial ECMO where the exchange is between 400 ml per minute to 1500 ml per minute rather than 4 to 5 liters per minute. Right? So if you can use a system of extracorporeal carbon dioxide removal in addition to the convention so that you can pitch the tidal volume lower, not at 6 ml, but at 3 to 4 ml. Right? So you may protect the lung better. So ladies and gentlemen, I want to conclude by saying we should be ventilating patients with ARDS with a lot of finesse and care. Okay, it's not like pumping air in and out. We have to have the concept of how the lung is responding, because there are two to tango. You have said, but how is the lung responding? What's happening in the lung? That has to be assessed. Maybe it will be assessed better and better as we have better bedside monitoring and imaging systems. Tidal volume and plateau pressure limits are well established. Peak titration needs to be individualized. Don't ask me how. That is still a vexed question. New mechanisms that are proposed to impact VD are the driving pressure and mechanical power. As new evidence is being looked for, it would be prudent to keep the driving pressure less than or equal to 15 or maximum 18 centimeter water, and respiratory rate, peak flow rate, and you see the rate of ascent as low as possible. Thank you. Do we have time for questions? Proportional assist ventilation is a good concept because it will adjust the mechanical power according to your own effort. Your effort is high, it will reduce the power, and vice versa. But we haven't got a single trial where proportional assist ventilation has given us better outcomes, and this form of ventilation has been there for more than 20 years. So that is a problem why it's not become popular. We couldn't show it actually in data. But on the basis of mechanical power, we can visualize better how it could help. Anybody else? Anything that will change your practice from our discussion? Tomorrow you are going to manage an ARDS patient. Would you do anything differently? If so, why? If you think it won't, then if so, why not? Would you look at the respiratory rate when you go back bedside tomorrow? You're not going to keep it at 30, are you? Huh? That's how it's changed me, this concept of mechanical power. And I'm not going to ignore the flow rate. I've always arbitrarily set a low flow rate in ARDS, 45 or so. Arbitrarily. Because that was a recommended one. But we didn't know why. Now we know better. Because it's a high rate. Two things. Firstly, it doesn't allow different alveolar units to get recruited. Some may be slow, others may be fast. Because there's so much heterogeneity. So firstly, you are not giving enough time for opening up all the potential alveoli that are waiting. And secondly, if it's very fast, you have more energy output into those small number of lung units which are receiving it. So I have another reason to keep the flow rate low. I'm going to look at mean airway pressure also. Right? I'm not going to allow very high of anything. Right? I don't know exactly in mathematical terms how much its contribution is, but I've understood that keep everything cool. Don't overdo anything. Okay, thank you very much.
Thank you, sir, for a very comprehensive talk.